Have you ever heard of a situation, maybe experienced it, where food makes someone incredibly sick, but all the standard allergy tests, they come back completely clear? It's this really puzzling scenario, leaves families totally confused, just searching for answers.
Yeah, it's incredibly frustrating.
Well, today, we're doing a deep dive into one condition that fits that description perfectly. Food Protein-Induced Enterocolitis Syndrome, or FPIES for short.
FPIES, right.
Our mission here is to really cut through that confusion, get to the essentials of FPIES, its history, which is quite surprising, its impact, and the whole journey that finally brought it into the light.
Yeah.
And the crucial thing to grasp right away is that FPIES isn't your typical allergy. It's what they call non-IgE mediated.
Right. Non-IgE, that's the key distinction.
Which means it doesn't set off that immediate alarm system in the body, the one causing hives or, breathing problems.
Exactly, and that's precisely why it's been so difficult to diagnose for so long.
Yeah.
And, that's also why FPIS has been such a source of, deep frustration for families for many, many years.
I can only imagine.
Imagine being a parent, right, watching your child have these severe reactions after eating specific foods, but then doctors are telling you, look, all the standard tests are normal.
Oh, wow.
There are no specific biomarkers, no simple blood test you can just run to confirm it. So for a long time, it genuinely was a medical mystery. Families felt really isolated.
Yeah.
But thankfully, through a lot of dedicated research and honestly incredible advocacy work, that's really starting to change. We're finally piecing together this really complex puzzle.
Okay, so let's unpack this then. What is FPIES exactly?
Okay.
At its core, it's described as a severe condition. It mainly affects infants and young children, and it causes these acute gastrointestinal symptoms.
Right. Severe gut reactions.
Think repetitive vomiting, often really forceful, projectile even, usually followed by watery diarrhea.
Yeah, that's the classic picture.
But here's the real kicker, the thing that makes it stand out. This severe reaction isn't immediate. It typically kicks in, 1 to 4 hours after the child eats the trigger food?
Exactly. That delay is absolutely characteristic. 1 to 4 hours for the vomiting, sometimes even longer, maybe 5 to 10 hours for the diarrhea to start.
And even though it's delayed, the symptoms can get really alarming, right?
Oh, absolutely. We're talking about reactions that can escalate pretty quickly to significant dehydration.
Dehydration, really.
Extreme lethargy. The child might look very pale. Their body temperature can drop, even low blood pressure, hypotension.
Wow.
And in the most severe cases, it can even progress to shock.
That sounds terrifying for a parent.
It is. It really is. But it's important to mention, despite how severe these acute reactions look and feel, there haven't been any reported deaths directly from an acute FPIES reaction.
That's somewhat reassuring, I suppose, but still incredibly serious.
Definitely serious. And it's so vital to understand how different this is from what most people think of as a food allergy.
Right. The typical peanut allergy image.
Exactly. With those common IgE-mediated allergies, you get hives, maybe swelling, breathing problems almost instantly. FPIES just completely bypasses that pathway.
That non-IgE pathway.
Right. It's non-IgE. And that's why the traditional allergy tests, the skin prick tests, the blood IgE tests, they just come back negative.
Which must have added so much confusion.
Absolutely. For years, it sent families and even clinicians down these endless rabbit holes trying to figure it out. It's not that the body isn't reacting, it's just reacting in a totally different, less understood way.
Okay. That delayed non-IgE reaction sounds incredibly challenging to pinpoint. So to really get a handle on this, maybe we should look back a bit. How did this condition even get recognized?
Yeah, that's a great idea. The history is quite revealing. It's a journey that started, over half a century ago, really.
Wow. So where did it begin?
The earliest sort of observations or mentions in medical literature go back to the 1960s.
60s, okay.
Yeah, like in 1967, a Dr. Grybowski described some cases. Then, a bit later in 1976, Dr. Powell reported on infants who had severe gut inflammation, enterocolitis, that seemed clearly linked to milk and soy proteins.
Milk and soy, interesting. Yeah. Early culprits.
Yes. And the symptoms were so intense back then, they sometimes even looked like necrotizing enterocolitis, or NEC, which is a very, very serious intestinal disease, mainly seen in premature newborns.
So potentially mimicking other severe conditions right from the start.
Exactly, which obviously complicates things. What's really fascinating, though, is just how slowly the understanding developed. Dr. Powell followed up in 1978, and she actually characterized it as milk and soy-induced enterocolitis of infancy.
Okay, so getting closer to a name.
Getting closer. But the actual term we use now, food protein-induced enterocolitis syndrome, FPIES, that wasn't officially coined until much later in 1998.
1998, so like a 20-year gap?
Roughly, yeah. It was Sitcherer and his colleagues who looked at the data and saw this consistent pattern of features that really warranted calling it a distinct syndrome. It just really highlights how tough it is to identify conditions when you don't have those clear biomarkers, those easy tests.
Makes sense.
Then a really huge leap forward came much more recently, in 2017.
Okay, what happened then?
That's when the first international consensus guidelines for FPIEs were published. An international working group came together.
Ah, consensus. That's always helpful.
Hugely helpful. It provided a global, unified definition and finally gave doctors worldwide a solid, evidence-based roadmap for diagnosing and managing FPIEs. It addressed a critical need.
Okay, that brings us more up to date. Now here's where it gets really interesting for me. How common is FPIES? And what are the things that actually trigger it?
Right. Good questions. For a long time, it was definitely considered rare.
That's what I would have thought.
Yeah, most people did. But newer studies are suggesting it's actually, well, not as uncommon as we believed. Some studies estimate the prevalence might be around 1% in infants in certain populations. For cow's milk FPIES specifically, cumulative incidence has been reported around 0.34%.
1%. That's not insignificant at all.
Not at all. It suggests this is a really significant, probably under-recognized issue affecting a fair number of infants.
So when does it typically show up?
Usually in infancy, often right when babies are introduced to cow's milk or soy-based formulas for the first time.
Or starting solids?
Or starting solids, exactly. Rice and oats are common first solid triggers. Interestingly, it's quite uncommon in babies who are exclusively breastfed.
Okay. And you mentioned different types earlier, acute versus chronic.
Right. That's an important distinction. Acute FPIES is that sudden, delayed, severe reaction we talked about happening sporadically after they eat the trigger food.
Got it.
Chronic FPIES is different. It involves more persistent, ongoing symptoms. Think regular diarrhea, maybe vomiting, poor weight gain, even failure to thrive because the trigger food is actually a regular part of the child's diet, maybe in their formula every day.
Ah, so it depends on the exposure pattern.
Exactly. And that chronic form tends to present even earlier, often in newborns, maybe under 2 months old.
Okay. Now the triggers. You mentioned milk, soy, rice, oats. Are those the main ones?
They are certainly the most commonly reported ones, especially cow's milk, which might account for up to 40% of cases in some studies. Soy is also very common. Rice and oats follow closely, particularly as first solid food triggers.
But it's not just those.
No, absolutely not. And this is crucial. FPIES can honestly be caused by any food protein.
Any food. Seriously.
Seriously. We're talking other grains, legumes like beans or peas, egg, poultry like chicken or turkey, fish and seafood, even a whole range of fruits and vegetables.
Wow. That makes finding the trigger incredibly difficult.
It can be. What's also interesting is that there seem to be geographic variations in the most common triggers, which probably just reflects different dietary patterns around the world.
Makes sense.
And while many infants only react to a single food, a pretty significant chunk, maybe 20 to 40% in some U.S. studies, react to multiple foods.
Often milk and soy together.
Yeah, that's a common pairing. Cow's milk and soy cross-reactivity is definitely a thing in FPIEs. There's also some limited data on baked milk or baked egg products, but generally, caution is advised there too.
Okay, so a wide range of triggers, single or multiple. Let's quickly recap those acute symptoms again, just to solidify it.
Good idea. So classic acute FPIES, repetitive vomiting is usually the first sign, starting 1 to 4 hours after ingestion.
Can it look different? The vomit.
Yeah, initially it might just be stomach contents, but after multiple episodes it can become bilious, meaning it contains bile, so it might look greenish or yellowish.
Okay, vomiting first. Then
typically comes watery diarrhea, usually delayed even further, maybe 5 to 10 hours after they eat the food.
And other signs.
Lethargy is very common. The child just seems wiped out, pallor, looking pale. And as we mentioned, more severe signs like low temperature or low blood pressure can develop. But the key is these acute symptoms usually resolve within about 24 hours once the trigger food is out of their system.
Right. Clears up relatively quickly, despite the severity. And chronic FPIEs.
Chronic is different. No dramatic single episode, but rather persistent, intermittent vomiting and diarrhea. And the big concern there is the impact over time. Poor weight gain, potentially leading to failure to thrive, especially in those very young infants.
Okay, so this brings us back to the underlying mechanism. You called it an immunologic mystery.
It still kind of is in many ways. We classify it as non-Ig mediated or sometimes call it cell mediated.
Cell mediated, meaning immune cells are directly involved, not antibodies like IgE.
That's the general idea. But the precise immune cascade, the exact steps that lead from eating the food to those dramatic gut symptoms and systemic effects, that's still not fully mapped out.
But we must know something about what's happening immunologically.
Oh, definitely. We know there's clear evidence of widespread systemic immune activation during an acute FPIES reaction. The body's defenses are clearly kicking into high gear.
Like what signs do we see?
Well, one really consistent finding is a significant increase in circulating neutrophils, a type of white blood cell, which typically peaks around 6 hours after the symptoms start.
Neutrophils. Okay.
It's so consistent, it's actually included as a minor criterion in some diagnostic guidelines.
Interesting. What else?
We also see activation of other immune cells, like eosinophils. There's evidence like elevated eosinophil-derived neurotoxin in the stool and activated eosinophils detected in blood samples.
So multiple types of white blood cells are involved.
Yes, it seems like a broader panleukocyte activation in the peripheral blood, potentially involving NK cells and monocytes too. And we see elevated levels of inflammatory markers and cytokines in the blood, things like IL-10, IL-8, IL-2, C-reactive protein, or CRP, all pointing towards significant inflammation.
So the immune system is clearly fired up.
Absolutely fired up. But this leads to a really important question, kind of a chicken and egg situation.
Which is?
Do these dramatic symptoms, like the vomiting and diarrhea, cause this widespread immune activation? Or does the immune activation actually cause the symptoms?
Well, maybe both arise from some common initial trigger we haven't identified yet.
Exactly. That's the crux of the mystery. It's a critical area where much more research is needed to really connect all those dots between the food trigger, the immune response, and the severe gut reaction.
That is a fascinating question. And given that uncertainty, it's probably no surprise that actually diagnosing FPIES is a major challenge.
Huge challenge. The tough reality for families and doctors is that it remains a purely clinical diagnosis.
Meaning no single definitive lab test.
Correct. It relies almost entirely on getting a really detailed patient history, recognizing that characteristic pattern of symptoms and timing.
So those 2017 international guidelines must be really crucial then.
Absolutely essential. They brought much-needed clarity and standardization. They lay out specific criteria.
What are the main ones?
There's one major criterion, that repetitive vomiting starting 1 to 4 hours after suspected food ingestion, and critically, without the typical IgE-mediated allergy symptoms like hives or wheezing.
Okay, vomiting 1 to 4 hours later, no hives.
Plus, you need at least 2 minor criteria from a list of 6. These include things like lethargy, pallor, that delayed diarrhea happening 5-10 hours later, low blood pressure, low body temperature, or that increase in neutrophil count we mentioned earlier.
Got it. Major plus 2 minors.
Right. And importantly, those guidelines also removed a previous informal age limit of around 9 months, recognizing that FPIES can definitely occur in older children, and even though rarely in adults.
Okay. But even with criteria, you mentioned mimics earlier, that must make it tricky.
Incredibly tricky. The differential diagnosis ruling out other things that look similar is absolutely critical and often difficult.
What are some common mimics for the acute form?
Well, the most common thing, especially in infants, is simple infectious gastroenteritis, a stomach bug.
Yeah. Vomiting and diarrhea, very common.
Exactly. But you also have to consider more serious things like pyloric stenosis, which is a narrowing of the stomach outlet, or intussusception, where the bowel telescopes on itself. Even sepsis needs to be considered sometimes.
And for the chronic form?
Yeah.
The persistent symptoms.
For chronic FPIEs, mimics might include things like severe gastroesophageal reflux disease, GERD, maybe other food intolerances, or food protein-induced proctocolitis, which usually causes just bloody stools but is milder. And in some cases, you even need to think about very early onset inflammatory bowel disease, VEOIBD.
So a lot to rule out.
A lot. But perhaps the most challenging group of mimics, especially for chronic FPIEs, are the inborn errors of metabolism, or IEMs.
Those rare genetic disorders.
Yes. They can look remarkably similar to FPI symptom-wise, particularly the chronic vomiting, diarrhea, and failure to thrive. This resemblance can unfortunately lead to significant delays in getting the correct diagnosis for the IEM, which can have serious consequences.
How can doctors tell them apart then? Are there clues?
Often, yes. Key differentiating factors are that IEMs might involve other things you typically don't see in FPIEs, things like neurodevelopmental problems, seizures, developmental delays, or maybe an enlarged liver, or specific facial features, dysmorphic features.
Okay, so looking for those extra signs is important.
Very important. And sometimes FPIEs can do strange things that hint at underlying issues. There was this fascinating case report.
Oh.
An infant diagnosed with FPIEs who, during the acute FPIES reactions, but only during the reactions, emitted a distinct fishy odor.
A fishy odor? Wow, what was that?
It turned out the FPIES reaction, the inflammation it caused, was unmasking an underlying mild genetic issue. This baby had slightly decreased activity of an enzyme called FMO3. Normally, it wasn't a problem, but during FPIEs, the body released a lot of choline, and this enzyme couldn't keep up with processing it. That led to a buildup of trimethylamine, or TMA.
Which smells fishy.
It's a perfect, albeit rare, example of how FPIEs can sometimes expose or interact with an underlying metabolic predisposition that might otherwise go unnoticed.
That's incredible. It really shows the complexity. Okay, so once FPIEs is diagnosed, how do you manage it? Let's start with an acute reaction happening right now.
Right. For an immediate acute FPIES reaction, the absolute primary treatment is aggressive rehydration.
Fluid.
Exactly. For milder reactions, oral rehydration solutions might be enough. But for moderate to severe reactions, intravenous IV fluids are essential to quickly replace what's being lost through vomiting and diarrhea and to treat or prevent shock.
Okay. Anything else besides fluids?
Yes. The antiemetic drug ondansetron, you might know it by the brand name Zofran, is often used.
To stop the vomiting.
Precisely. It helps stop the vomiting and limit further fluid loss. It's usually given either by injection into the muscle or intravenously.
What about epinephrine, like an EpiPen? People associate that with severe allergies.
That's a really important point. Epinephrine autoinjectors are not routinely prescribed or indicated for typical FPIES reactions.
Why not?
Because the hypotension, the low blood pressure you sometimes see in severe FPIEs, is thought to be primarily due to the massive fluid loss, leading to hypovolemic shock, rather than the vasodilation you see in typical IgE-mediated anaphylaxis.
So fluids are the key treatment for the low blood pressure in FPIEs, not epinephrine.
Generally, yes. Fluids are the mainstay.
Okay, that's the acute management. What about long-term? How do families live with this day to day?
Long-term management really centers on one main thing: strict dietary elimination of the identified trigger food or foods.
Complete avoidance. No cheating.
Complete avoidance. Unfortunately, unlike some IgE allergies where there might be a known threshold, no safe threshold dose has been established for FPIES triggers. So avoidance needs to be strict.
That sounds challenging, especially if it's a staple food.
It is extremely challenging. That's why working closely with a registered dietitian who has experience in food allergies is almost always necessary.
To make sure the child gets enough nutrition.
Exactly. To ensure adequate nutritional intake, prevent deficiencies, and help families navigate food labels, cross-contamination risks, and finding safe alternatives.
How about introducing new foods? How is that handled?
Very carefully. Typically, the approach is to introduce one new single-ingredient food at a time. Yes, gradually increasing the portion size over maybe 7 to 10 days, while continuing to give all the foods that are already known to be tolerated. It's a methodical process.
And for babies, what about breast milk or formula?
For exclusively breastfed infants who react to something the mother ate, sometimes maternal dietary elimination is tried, but honestly, it's rarely needed or recommended as the primary approach for FPIEs. For formula-fed infants who react to standard cow's milk or soy formula.
Then what?
Then the recommendation is to switch to an extensively hydrolyzed formula where the proteins are broken down significantly, or sometimes even an elemental formula where the proteins are completely broken down into amino acids.
Okay, now the big question every parent must ask.
Yeah.
Do kids outgrow FPIEs?
That's the hopeful question, yes. And the answer is, it varies. The natural history of FPIEs is quite heterogeneous. It depends on the country, the specific food trigger, maybe other individual factors.
No, general.
Generally, most children with FPIES to cow's milk and soy tend to outgrow it, meaning they develop tolerance, by ages 3 to 5. Some international studies even report faster resolution rates.
Okay, so there's definitely hope, especially for milk and soy. What about solid food triggers?
FPIES, triggered by solid foods like rice, oats, or others, seems to have a more variable and often more prolonged course. Some children might outgrow it, but it can persist longer, sometimes even into adolescence or adulthood.
How do you know if they've outgrown it? You can't just try the food at home, right?
Absolutely not. The way to determine if tolerance has developed is through a medically supervised oral food challenge, or OSE.
Done in a clinic or hospital.
Yes, always in a controlled setting where a reaction can be safely managed. The food is given in gradually increasing amounts under close observation.
Okay. And one more thing here. You mentioned atypical FPIEs earlier.
Yeah.
Where kids develop IgE antibodies.
Right. Sometimes a child who initially presents with classic FPIE symptoms might later develop specific IgE antibodies to that same food trigger. We call this atypical FPIEs.
What does that mean for them?
It often indicates a potentially slower rate of developing tolerance, meaning they might not outgrow the FPIES as quickly. It also means they might be at risk for developing immediate IgE-mediated reactions to that food later on. So those kids need careful monitoring, including regular IgE testing.
Okay, that adds another layer of complexity. So putting this all together, what does this actually mean for the families living with FPIES day in and day out?
It means a really significant impact on quality of life for both the child and their caregivers.
More so than typical allergies, you think?
Interestingly, yes. Some studies have actually shown that the burden on caregivers, the stress, the anxiety, the lifestyle changes, can be higher for families dealing with FPIES than for those managing the more common IgE-mediated food allergies.
Wow. Why do you think that is?
It could be a combination of factors: the severity and scariness of the acute reactions, the diagnostic delays they often face, the uncertainty, the extreme dietary restrictions needed, especially if multiple staple foods are involved. It affects social life, eating out, school, daycare, everything.
I can see that, the constant vigilance.
Exactly. And the emotional and practical hurdles are just immense. Think about the nutritional worries. The social isolation birthday parties become minefields. And historically, as we touched on, a huge barrier was a lack of awareness among healthcare providers themselves.
Leading to those diagnostic delays.
Agonizing delays, sometimes years. Parents felt unheard, dismissed, sometimes even accused of making things up or causing the illness themselves.
That's awful.
It really is. And this brings us to the story of Fallon Schultz Matney,
who founded the advocacy group.
Yes, she founded the International FPIES Association, IFPIES. Her son, Landon, suffered for 2 incredibly difficult years with reactions to over 30 different foods.
30. Oh, my goodness.
30.
Yeah.
They battled to get insurance coverage for the essential elemental formula he needed, which cost something like $2,000 a month back then. And horrifyingly, she even faced accusations of Munchausen by proxy fabricating her son's illness.
That's unbelievable.
Unbelievable, but it happened. So, fueled by that experience, she decided enough was enough. She started IFPIES to support other families and fight for recognition and research.
And that advocacy made a difference.
A monumental difference. Parent advocacy, really epitomized by IFPIES, completely changed the landscape for FPIES. They directly challenged a medical community where dismissal, saying things like FPIES isn't real, was sadly common.
How did they challenge it?
By sharing their stories, connecting families, demanding answers, pushing for research. Their relentless efforts led directly to a dramatic increase in FPIES publications and research funding. And ultimately, their work was instrumental in bringing together the experts who developed those crucial 2017 international consensus guidelines we discussed.
Wow. So parent power really drove the science forward.
Absolutely. And perhaps the most visible symbol of their success was petitioning the U.S. Congress to establish National FPIES Awareness Day.
Which day is that?
May 4th. And they succeeded. It was co-sponsored by Senators Cory Booker and Patrick Toomey, a direct result of tireless advocacy by parents who refused to be ignored. It's an incredible story of grassroots impact.
That truly is inspiring, and it highlights the need for better systems, right?
Exactly. And another crucial development spurred by this movement was the creation of dedicated, multi-specialty FPIES clinics.
Bringing different specialists together.
Yes. Clinics that combine expertise from allergy immunology, gastroenterology, and nutrition, all under one roof, focus specifically on FPIES.
That makes so much sense.
It arose directly from recognizing the need for coordinated care. These centers validated the parents' concerns, provided expertise that was often lacking elsewhere, and have significantly sped up diagnosis times and improved the management strategies, especially for the most complex cases. It's made a tangible difference for countless families.
Okay, so let's try and summarize this deep dive. FPIES. It's a distinct type of food allergy, non-IgE mediated.
Right. Characterized by those severe but delayed gastrointestinal reactions, mainly vomiting and diarrhea.
Mostly affecting infants and young children, though it can persist.
Yes, and diagnosis is clinical, based on history and recognizing the pattern, which has historically been challenging.
But increased awareness, those international guidelines and the development of specialized multi-specialty care are really transforming outcomes.
Definitely improving things significantly. We've honestly come such a long way from FPIES being dismissed as an immunologic mystery or just a rare disease.
Which leads to a final thought, perhaps.
I think it does. It makes you wonder, doesn't it? What more will we discover? How much further can we advance our understanding and care, not just for FPIEs, but for other complex conditions?
If we do what?
If we really commit to listening closely to our patients and their families, if we embrace that kind of interdisciplinary collaboration we see in the FPIES clinics, and if we continue to champion dedicated research, even into conditions that might seem uncommon at first glance.
A powerful reminder. We hope this deep dive has shed some light on FPIES for you, maybe inspires you to think about that incredible power of informed advocacy, combined with relentless scientific curiosity, to drive real medical progress.